Welcome to part 2 of pediatric asthma. In this part, we will discuss about management of pediatric asthma. Management of asthma is classified into management of acute exacerbations and long-term management. To start from long-term management of asthma should have the following components. Those are assessment and the monitoring of disease activity, education to enhance patient and the family knowledge about asthma, identification and the management of precipitating factors and the comorbid conditions that worsen asthma, and appropriate selection of medications to address the patient's need. The long-term goal of asthma management is attainment of optimal asthma control. When we see assessment and the monitoring of disease activity, regular assessment and the monitoring are based on the concepts of asthma severity, asthma control, and responsiveness to therapy. Asthma severity is the intrinsic intensity of disease, and assessment is generally most accurate in patients not receiving controller therapy. Therefore, assessing asthma severity directs the initial level of treatment. The two general categories are intermittent asthma and the persistent asthma. Persistent asthma is further divided into mild, moderate, and severe persistent asthma. All levels of persistent asthma should be treated daily with inhaled corticosteroid therapy to reduce airway inflammation and improve long-term control. We classify asthma into intermittent and the persistent, then the persistent one into mild, moderate, and severe based on the frequency of symptoms during day and the night time, and also based on the percent predicted forced expiratory volume to forced vital capacity and the variability of peak expiratory flow rate. This is based on Global Initiative for Asthma Severity Classification. The degree of impairment and the presence of risk are used to determine the patient's level of asthma control after treatment is started. We classify asthma control into well-controlled, not well-controlled or partially controlled, and poorly controlled. Children with well-controlled asthma have daytime symptom less than or equal to 2 times during daytime per week and need a rescue bronchodilator less than or equal to 2 times a day per week and no interference with normal activity and less than 2 exacerbations in the past year. So in this table, we will see level of asthma control based on daytime symptoms, limitation of activities, nocturnal symptoms, need for reliever or rescue treatment, and the lung function, and also exacerbation. So always on follow-up, we should have to classify the severity or the level of asthma control as controlled, partially controlled, and uncontrolled. Second important part of asthma treatment is patient and the family education. Basic understanding of the pathogenesis of asthma can help children with asthma and their parents understand the importance of recommendations aimed at reducing airway inflammation to achieve and maintain good asthma control. It is helpful to specify the exacerbation of good asthma control resulting from optimal asthma management and addressing concerns about potential adverse effects of asthma pharmacotherapy agents, especially their risk relative to their benefits. The third is control of factors contributing to asthma severity. Eliminate or reduce problematic environmental exposures. Environmental tobacco smoke elimination or reduction in home allergen exposure elimination or reduction in sensitized asthmatic patient. And also we should have to eradicate or eliminate other airway irritants such as cool burning smoke, strong chemical odors, perfumes, and dusts. And we should have to also treat comorbid conditions. As we have said, the most comorbid condition in asthma is allergic rhinitis and gastroesophageal reflux. We should have to treat those comorbid conditions to control asthma appropriately. The fourth principles of asthma pharmacotherapy. There are 6 treatment steps. Patients at treatment step 1 have intermittent asthma. Children with mild persistent asthma are at treatment step 2. Children with moderate persistent asthma can be treated at treatment step 3 and 4, and severe persistent asthma are treatment step 5 and 6. The goal of therapy are to achieve a well-controlled state by reducing the components of both impairment and the risk. Impairment are preventing or minimizing symptoms, infrequently needing quick reliever medication, maintaining normal lung function and the normal activity levels. Whereas reducing the components of risk include preventing recurrent exacerbations, reducing lung growth, and medication adverse effects. Asthma treatment can be administered in different ways, inhaled, oral, or by injection. But inhaled therapy drugs are delivered directly into the airways, producing higher local concentration with significantly less risk of systemic side effects. So, inhaled therapy route is preferred. Asthma treatment medications are classified into controllers and relievers. Controllers are medication to be taken on daily long-term basis, mainly inhaled corticosteroid and long-acting beta agonists, and also others. And relievers are medication to be used on as needed basis to relieve symptoms quickly. Corticosteroids are the most potent and the most effective medications used to treat both the acute and the chronic manifestation of asthma. Inhaled corticosteroids are the backbone of persistent asthma therapy. Inhaled corticosteroid therapy improves lung function, reduce asthma symptoms, reduce airway hyperresponsiveness, reduce use of rescue medications, improves quality of life, reduce the need for prednisolone, and reduce urgent care visit and hospitalization by half or approximately 50%. Those inhaled corticosteroids include beclomethasone, budesonide, fluticasone, and mometazone puff. This is the mechanism by which bronchodilator and the inhaled corticosteroid works. Bronchodilates dilate the airway, whereas inhaled steroids reduce edema and the swelling. So combined therapy is very important in achieving controlling asthma. This table shows the 6 steps of asthma treatment based on their severity, from step 1 to step 6 based on their severity. Monitoring is essential to maintain control and establish the lowest step and reduce treatment to minimize the cost and maximize safety. Always we should have to follow step up and the step down approach. If asthma is not controlled, step up the treatment to upper step and improvement is generally seen within 1 month. If asthma is partially controlled, consider stepping up treatment, and if controlled asthma is maintained for at least 3 months, step down with a gradual stepwise reduction in treatment. Always address administration technique, adherence, treating comorbidities, and eliminating triggering factors before stepping up. The goal is to decrease treatment to the least medication necessary to maintain control. When we see asthma exacerbation and their management, asthma exacerbation are acute or subacute episodes of progressively worsening symptoms and airflow obstruction. Airflow obstruction during exacerbation can become extensive, resulting in life-threatening respiratory insufficiency. Often, asthma exacerbation worsens during sleep, between midnight and up to 8 a.m. Admission to emergency room and the close monitoring of clinical status, hydration, and oxygenation are essential elements of immediate treatment. Supplemental oxygen, frequent administration of inhaled bronchodilator, and the systemic corticosteroid therapy are the conventional intervention for children admitted to the hospital for asthma exacerbation. Immediate treatment with rescue medications such as inhaled short-acting beta agonist, up to 3 treatments in 1 hour, and a short course of oral corticosteroid therapy, 1 to 2 mg per kg per day prednisolone for 3 to 5 days should be instituted in addition to inhaled beta agonist therapy for acute asthma exacerbation. IV or IM dexamethasone has been found to be effective alternative to prednisolone and with a lower incidence of emesis. Rarely, an IM injection of epinephrine and other beta agonists and IV or IM magnesium sulfate might be administered in severe cases. After admitting a child for asthma exacerbation, the discharge criteria were no accessory muscle use, minimal or completely dissolved breathing, and oxygen saturation more than 90% at room air for more than 4 hours, and no treble talking and can speak in full sentence. At discharge, continue prednisolone for 3 to 5 days, escalate controller, educate family about triggering factors, and appointment after 2 to 5 days for reevaluating the patient. This is all about asthma management in children. Thank you for watching.